My name's Paul Jauncey. I'm one of the physician training medical directors with the Queensland Basic Physician Training Adult Medicine Network. I'm also the Director of Physician Education up on the Sunshine Coast and a general physician up here as well. So this is a talk designed for trainees who have already done 1 year of physician training and are looking at applying to the 2-year physician network. Now this is a little bit more complex because previously this would just be applying for the network. We've held this talk a number of years going now, and traditionally it's been in a auditorium with people available and wine and cheese and other sorts of snacks and a chance to mingle with people from all the different rotations. But unfortunately, due to some fairly significant events in the community, we're doing this via telehealth. But the key thing is this is for people who are looking at applying for a medical registrar job and completing 2 years of basic training after this one and looking at sitting their exams in 2022. So basically the goal of this session is briefly to go through a little bit about physician training in Queensland. We may have some interstate people joining us today, so we'll cover how physician training works and go over some of the key concepts that lead to how we structure physician training the way we do. We'll also go through the different training rotations that we have in Queensland. And as I said, traditionally we used to get people to come along and tell you in person about their own training rotations. Unfortunately, I'll have to do my best to outline the different training rotations myself. But online there are some videos that go through the various opportunities in the different training rotations. We will go through some of the mechanics of outlining the selection and application process. And also, as I said, we'll have an opportunity to ask questions as we go through. So just quickly, in terms of physician training, the way that we think about this at the network, and this is shared with all the DPEs across the state, is that pathway to becoming a physician involves a pre-vocational stage, which obviously is your mandatory internship year, and in general, for most trainees, 2 years of pre-vocational work, so intern year and a non-stream JHO term. And this allows a good foundation in generalist practice across all the specialties. And most DPEs, as I said, believe that PGY3 is generally the best time to apply for physician training, as it allows you to get that good generalist background, which allows you then to probably function a bit more roundedly as a physician with the understanding of how surgeons or obstetricians or pediatricians may think. Then we go into basic physician training, which, as we all know, is a minimum of 3 years and involves workplace-based assessments, as well as the big written and clinical exams, which obviously this year are being held. The clinical exam is being held up, and that's added another sting to the changes this year. And then the advanced training. So for the people here tonight are basically those people who are a third of the way through that light green box of basic physician training, and often either having done a year as a registrar or more often as a SHO, and are looking to pivoting into their last 2 years of registrar practice and start looking towards the written and clinical exams in 2022. Now, when we think of physician training, there are a number of players involved. Obviously, the trainee is at the centre, doing both workforce work as well as studying and putting in the hard hours, doing the long cases, doing the short cases, attending sessions, presenting, all the things that make up basic physician training. Training is a vocational training, therefore it exists in a workplace. So the employing hospitals obviously play a major role. They provide employment, they pay the salary, they pay for physician training through the vocational training subsidy. They also provide the examiners who do weekend exams. They provide the people who do tutorials, the people who do educational supervisor reports. So the employing hospitals invest significant resources into the trainee. They obviously receive the services of the trainee as an employee throughout that time as well. Then there's the RACP, is the other major organisation involved in physician training, who set the standard for physician training, accredit the hospitals as training settings. They also generate educational resources, most notably the College Learning Series, and also provide education and mentorship for supervisors and directors of physician education. Then there's the DPE, who is the sort of interface between the hospital and the RACP on the ground, and obviously the person who, in a sense, has direct supervision over you at your local hospital. Whilst there's someone who is employed and often paid specifically by the hospital to be your DPE, they actually are appointed by the college. So they're a college representative working in the hospital. although obviously they function as an intermediary, helping the hospital and the college work together to deliver a training program that benefits you. And then above all of that is the physician training network, which helps the employing hospitals work together, DPEs work together to deliver physician training across the state. We also work closely in with the college and are involved in innovations in college policies, most notably the educational renewal that's undergoing at the moment. And so the goal is, whilst some of these organisations may have slightly different priorities and different viewpoints, we try to work together as a team to deliver a training program, which is the overall experience you go through as a trainee that allows you to go from being a junior house officer to being an advanced training ready basic physician trainee at the end of your 3rd year. So when I think about basic physician training, it used to sort of be very heavily focused on time-based training. Find a reg job, get through your 3 years, get through the exams, that's basic training. However, the college has sort of changed things a little bit. Obviously, still we have time-based training requirements. You still need to get your subspecialty time, and you still need to move around through a variety of settings. You still need to do your level 3 time. However, the college is also recognising that there is more to training than just being in the job, and supervision is playing a bigger role. For those of you who've looked through education renewal, there's a lot more of a focus on workplace-based assessments. At the moment, we've got mini CEX, learning needs analysis, your supervisor reports, your professional quality reflections, as well as then the final exam. And what we need to do to deliver basic training is make sure that we have a system whereby people get their time-based requirements. They're in a training program that allows them to meet those other workplace-based requirements, and then obviously be in an environment that allows them to pass both the written and clinical examination. And I suppose perhaps becoming increasingly important, also be in a situation whereby they have the right skills and experience needed to progress to advanced training. So how does the network help achieve these goals from a trainee perspective? So first of all, the network takes ownership on trying to make sure that trainees meet their RECP requirements. When you sign up to a 2-year training network, the goal is in those 2 years, or by the end of those 2 years, you should have made all your time-based training requirements. You should also be aided in meeting your workplace-based assessments as well. Having a network of different training settings allows trainees to move through a number of different training environments. Medical practice in Metropolitan Tertiary Hospital is quite different from what you might experience in, say, Gympie Hospital, where I've worked before. Also, it provides trainees with the experience to work in settings with potential long-term employment opportunities. Unfortunately, the workforce needs in metropolitan centres are starting to get saturated, especially in the public system. And so a number of trainees will likely be getting jobs in smaller metropolitan hospitals or regional hospitals, or potentially the private setting. The network also helps provide equitable access to examination preparation across all the different sites, as exam resourcing is becoming an increasing pressure for training settings as well as the college. And by working together, we can try and make sure everyone gets a shot at exam preparation. The other thing that the network does is it provides a single centralised application process. For everyone on this call, obviously that's only in the 2nd year of physician training, although we're trying to transition that to the beginning of physician training. Previously, what used to happen was you just have to send out your CV to all the different DPEs across the state and interview 3 or 4 times. Here we have one centralised interview, one centralised application process that's valid across all the training settings in the state. I suppose one thing we need to highlight that's a little bit of a change from where things have been before is that from 2021, approval of basic training will only be occurring for trainees who are working in network hospitals, especially for definitely in the BPT2 and onwards setting. And that's a bit of a change from before where we had network trainees and non-network trainees. The rationale behind that is probably relating to that first bullet point there, whereby if you're doing non-network training, you might be in a situation where you did not get a chance to meet all your training requirements, and suddenly you'd have people who are not having enough subspecialty time or tertiary time in order to progress into advanced training, despite having worked as a basic physician training for 3 years. So based on that, we're shifting towards network-only training. That's also consistent with the college's principles of education leadership. Now, how's the network aid the training hospitals? Well, we do provide an equitable distribution of workforce, looking at workforce needs across the state rather than just internally. We allow sharing of examination preparation workload through our clinical exam prep program, organising the online practice exam, rather than every institution doing their own practice exam or their own lectures on how to do a live-along case. We're able to put those resources together, share them across the state, and allow the local supervisors to focus more on the job practical training, which in the end is a lot more useful for passing the exams as well as your general practice. It also helps us provide communication networks whereby if there's an issue of any sort, we have all the DPs in the one room talking to each other, trying to work out a solution for a trainee or at a greater level. The network also acts as an expert on RSEP policy changes and often advises the RSEP with regards to what's important for Queensland. And so it allows us to keep up to date, make sure we're at the cutting edge of RSEP practice. So I'll just talk a little bit about the network rotations. And as some of you may be aware, there are 5 rotations across the state. As you can see, they're different sizes and very different, made up of different constituent hospitals. And this leads to a different training experience in each of the different rotations. So the Far North rotation has Cairns as its level 3 hospital with a short amount of secondment time to Atherton and Innisfail. So it does mean that over the 2 years, we're talking about the 2-year network here, the trainee will spend most of its time in Cairns Hospital and doesn't need to move anywhere else. They still get exposed to all the subspecialties that are offered in a tertiary hospital. North Queensland similarly is based at Townsville Hospital with a common site to Mount Isa. In this case, it's a flyaway term, but certainly you'll see some medicine out there that you wouldn't see elsewhere. I should also highlight that the North Queensland rotation in Townsville Hospital is one of the pilot sites for the new curriculum, which unfortunately some of those plans have been held up by COVID, but it's one of the few sites in addition to the Gold Coast that is trialling a new curriculum across Australia and New Zealand. I might talk about the coastal rotation next. A little bit more complex than the Queensland rotations, but based out of Gold Coast as the level 3 hospital with rotations to Logan, Redland and Robina. As I said, Gold Coast is trialling the new curriculum as well. And you might also notice that all those hospitals are within driving distance. So again, the coastal rotation, the Far North and the North Queensland are hospitals where you can spend pretty much all your training, bar the secondment to Mount Isa, in the one setting and you don't need to move. Now, I'll move on to the north side rotation next. As you can see, different to the other rotations, there are 3 tertiary hospitals on the north side. And in the 2-year network, normally people are based at one of those hospitals as their tertiary base. So we've got the Royal Brisbane, Sunshine Coast, Prince Charles, with a number of level 2s, Caboolture, Mackay, Redcliffe and Rockhampton. And up here on the Sunshine Coast, we also have Nambour and Gympie. Now, one thing to note there is that Mackay and Rockhampton are part of this rotation. So if you choose the north side rotation, it's likely that you may have to do a flyaway rotation. So in order to choose the north side rotation, you basically should be prepared to do a flyaway rotation to Mackay and Rockhampton. One thing that's changing on the north side, previously we would do 2 3-month rotations over the 2-year period. Now we're looking at doing 6-month rotations away. The rationale for that being you get a much more immersive experience by going to a hospital for 6 months rather than 3 months. So that will be changing next year. Then finally, the south side rotation again has 3 level 3 hospitals, Greenslopes, PA and Marta. I guess the idiosyncrasy of the south side is it's the only rotation that actually involves rotations to private hospitals. And so it gives a bit of exposure to that private medicine, which may be very important for those people who are looking at metropolitan jobs in the long term, where a private portion will likely be a component. It has drive-away rotations to Logan and QE2 and Ipswich, and slightly longer drive-away rotations to Toowoomba, Bundaberg and Hervey Bay. So again, the Southside rotation has 6-month Southside rotation has 6-month placements, and if you elect to go for the Southside, then it's important to bear in mind that there's a high likelihood you might have to do a rotation that is based away from Brisbane. So how to choose a rotation? So there's 2 broad categories, I think: training factors and lifestyle factors. So training factors are the terms that are offered in the different hospitals. Whilst there's a lot of commonality, there's level 3 hospitals which give access to most of the subspecialties. only certain rotations may have access to transplant medicine and different access to cardiac transplant or renal transplant. There's subtle differences in some of the terms offered. So talk to the current registrars who are working in those rotations to get a feel for what's offered. I think it's important to think whether you're prepared to do a flyaway rotation. If you're not prepared to do a flyaway rotation, then I would suggest you really think whether you should be applying to the north side, and particularly the north side, which involves Mackay and Rockhampton, which are true flyaway. Similarly, if you're not prepared to move away from Brisbane for a prolonged period of time, then maybe you want to think about going to the Gold Coast, Townsville or Cairns, where you can base yourself and your family in the one situation for the entire time. Obviously, the south side still involves lengthy drive away to Harvey Bay and Bundaberg, but I guess the difference there is it's still somewhat feasible to drive back for a weekend, although obviously you have to be careful with fatigue. That's quite a long drive. It's important to find out about the work environment. Some hospitals tend not to do rostered overtime. SCU is one of those. And what sort of hours a trainee would normally work, because even though there might be rostered overtime, there might be unrostered overtime. What the access to subspecialty terms are, whilst most hospitals will have access to a vast variety of subspecialty terms, some hospitals tend to be able to afford more subspecialty terms each year. So talk to the current registrars, talk to the DPEs in the hospital you're looking at applying to. And the other thing is hospital size. Some people prefer to work in big institutions. Some people prefer smaller hospitals. And most of the level 3 hospitals are quite big hospitals, but there's slightly different vibes between them. And then the other thing is to think about lifestyle factors. Where do you want to live? Where can your partner get a job? I should say, for those of you who've got partners who are in medicine, sometimes some of the smaller regional hospitals are able to arrange joint placements a little bit more easily than the metropolitan hospitals can. Again, just explore that with the DPEs of the hospitals you're looking at. It's probably worthwhile thinking, where can you get a job in 5 years' time when you've finished your advanced training? And also think, what do you want to do outside of medicine? If you want to go diving on the reef, you can go to Cairns. If you want to go surfing, come to the Sunshine Coast. Think about what's around, talk to the trainees who work in that area. And as we said, on our network website, there's rotation videos that allow you to get a bit of a feel for what the experiences can be like. So just talking about placements, as I said, across all networks, the placements will be for a minimum of 6 months duration. And you really should expect to complete at least one flyaway rotation through the course of your basic training. Some people may not get allocated to a flyaway rotation, but if you apply to a rotation that has flyaway rotations, you should be prepared to take that, because in general, it's fairly allocated across all trainees. And I think the other thing is that the key thing to think is that the 2-year network is for trainees undertaking a 2nd and 3rd year of training who are thinking of sitting their exam up to 2022 and then potentially 2023. There's an option for an extra year if you choose to defer for some reason, or to accommodate an unsuccessful attempt at the exam. So in terms of eligibility, so we sort of covered this. To be eligible for the 2-year network, you've obviously got to hold general registration with the Medical Board of Australia, which you need to do to be an RECP trainee. You've got to be registered with the college as a basic trainee, and you've got to have a minimum of 44 weeks of prospectively accredited training terms. That's the reason for that. That means you'll be eligible to go into BPT 3 in 2022, and basically you'll be ready to sit your exams in 2022 if you do next year's full time. If you've got less than 44 weeks of prospectively accredited training terms, you're best applying to the 3-year network. Now, the next thing is, am I suitable? And this is the selection criteria we're using, which is designed to reflect what the college has intimated what a physician should be and what our DPEs think a physician should be. So firstly, looking at the trainee as a learner. It's a vocational training program. It's all about learning. The next is, as we said before, the state invests a fair bit of resources in terms of training physician trainees. And so we want to make sure that people are committed to providing a service to the people of Queensland, and in particular, regional and remote Queensland, who are also investing just as much and often at significant social disadvantage. We look at the trainee as a team member. Medicine is much more team-based than ever, and as you all know from your day-to-day practice, being part of a team, especially a multidisciplinary team, is very important for a functioning med-reg. We look at the trainee as a professional, and I encourage any of you to look at the, if you haven't already, to look at the professional practice framework, which the college has on its website. I like to call it the college pinwheel. It's the series of skills around the outside of the medical expertise: communication, leadership, education, advocacy. We look at the trainee as a decision maker. As a registrar, your job will be making those tough calls after hours, and that tough call may even be, should I wake the boss up in the middle of the night? And also we look at the safety of a trainee performing after hours duties, because applying for a medical registrar job, we need to make sure that people are suitable to be that medical registrar on the phone or on the Met team after hours. So how will we be selecting you? So we use a number of tools. Firstly, we get a recommendation from your current DPE suggesting that you're suitable to continue on with training. And in general, if that recommendation is not forthcoming, you should already know about it. The DPE should already be supporting you through those processes. Next, the RMO campaign, and we'll go through the mechanics of this, has some specific network questions. So when you get to those questions, just make sure you spend a bit of time focusing on those answers, because we do mark them and that contributes to the scoring. We look at your CV, particularly your previous experience in education, leadership, a little bit of research, and we look at referee reports. And then finally, there's an interview. I think I'll talk about the interview format and what we do and don't know about the interview format later. But just the key thing I'd highlight with the interview is that it's going to be clinical and professional domains, not just how do you manage this person who's deteriorating after hours, but how do you manage family members? How do you manage a team? So I might just quickly mention, so I thought we had another slide there. With the interview, it's difficult for us to say how the interview is going to look because we're uncertain what's happening with COVID at the moment. One thing I think it will be, if you've heard any murmuring about it changing to the interview format, at the moment we're going to be keeping the same style of interview and a panel interview with similar questions to previous years. Whether it's going to be an in-person interview or through some sort of telehealth medium, that depends on what we can do with social distancing. We don't have the answer right now because no one has the answer. Fortunately, things seem to be settling down with COVID, but we just need to see what happens. So we'll just go through some of the details as to how to apply. Now, this guideline is all up on the website, so you will be able to find this information later on. Please do not feel you have to memorize it all now. So first thing, all RMO jobs, no matter what they are, have to go through the RMO campaign in Queensland. And when you apply, there'll be an option for, are you applying for a position on the Queensland Basic Physician Training Network, adult medicine? And then select yes, because that's what you're doing. So as long as you select that, then you should be able to follow the questions thereafter. One of the things you'll need to do when you're going through that process is supply evidence of 44 weeks of prospectively accredited terms. And at the moment, based on what the college is saying, if you've been seconded into a COVID unit, we're certainly considering that as prospectively accredited terms. So all you need to do that is show a screenshot of your RACP portal. And if you show a screenshot of your RACP portal, showing those terms have been approved, that's what we need. So when we ask for that, it's just print screen of the RACP portal showing the outline, as you can see here, of the accredited terms. So there's 5 short statements. 1, what is your plan for basic training? We're talking about trainees as learners. Commitment to and participation in clinical teaching and education, possibly citing examples. Your exposure in leadership and quality improvement. Your commitment to the health of Queenslanders, and evidence of any research activities you may have achieved in your time so far. So you'll see these, they'll be free text questions with a word limit. So just make sure you fill those out. Remember, they're part of your scoring for your application. Now there's a clinical experience template. We use that so we've got a bit of a database of what terms people are doing, basically to help work out what terms you might need in the future and help with allocations. And make sure you include your planned terms for the rest of 2020. You know, things may change, things can change at any time, but the most information you have, that's better. And including employment up to the last 3 years, including internship. And then preference a minimum of 3 training rotations out of those 5 rotations we saw before. Thinking about those things we talked about before. Please don't preference rotations that you'd never ever take a job. It's just a bit awkward when someone approaches you from a hospital or from a rotation that you're never going to take a job in, and you have to say no. So if you're not going to take a job, say no. Don't preference it. But we believe everyone should be able to find at least 3 rotations they'd be willing to work in. Upload your current curriculum vitae, and there is a Q Health template available on the RMO campaign website, and just make sure you're sort of addressing those selection criteria we outlined before. So when you're preferencing the network, it's important to select, as we've said here, so facility, college pathway, network determined, registrar, specialty medicine, subspecialty basic physician training. My advice to you is when you actually go through the RMO campaign, get the how to apply FAQ from our website and just have it open on a separate screen or print it out in front of you and just walk through it. It's the safest way to make sure you do everything and end up where you want to be. So nominate your referees. The first referee should be your immediate clinical supervisor, and the second referee should be your most recent supervising physician. So we know that you may be working in DEM or a non-medical term, so we do want to have at least one physician referee. It's useful to make sure your referees are aware that the report contributes to your ranking, and please make sure that the referees use institutional mail addresses. Some of you are applying from Greenslopes, and we do understand that they will have they'll have their own organisational email based on their private practice, and we do have a bit of a database of those. So as long as they're using a work-based email, and for anyone in Queensland Health or MARTA, if they're using the health.qld or the MARTA email address, that'll be fine. But we just don't want it from personal email, so we can make sure the referee is coming from the right source. And when a referee goes through a report, there might be certain areas, for instance, there is a research question, there's leadership questions, which they may not be able to assess as for a resident that's applying. A lot of those things, we either know that they're not applicable for a resident level, or we assess them elsewhere in your CV. So if they're putting down not observed, that's not a major issue for those domains that you wouldn't necessarily get exposure to as a resident. If it's history taking or communication with patients, if it's not observed, that's probably a little bit more concerning. But certainly some of the higher level things which you may not have had exposure to, it's okay if they put not observed. And then basically, if through this process you're shortlisted, and you'll be required to undertake the interview. And as we said, interview dates and format are still to be decided. And basically, the key thing is, what we're trying to find out is this person a safe registrar BPT? We're not expecting you to manage someone to an ICU consultant level. We're expecting to make sure you can safely be the consultant delegate on the ward. So just think, what would a safe BPT 2 first-year registrar be doing in that situation? And often it's the simple things that people come unstuck with. And then based on all these metrics, we come up with an overall score, which comes up with a ranking list. Now, in terms of the outcomes, starting at the bottom, there are a few areas, both in the referee reports and in the interview, where you can actually fail and be deemed not suitable. In that case, you'll be notified that you've been deemed not suitable, and you have to apply for a non-training PHO or SHO position. And you won't be going onto the network, you'll be going to a non-training position, and then you can apply the year after. Obviously, you'll have a bit of BPT time under your belt, but we are having processes in place in the 3-year network for those trainees who have a little bit of time under in their experience. Then, if you pass the interview and pass the referee reports, you'll be deemed as suitable. And then depending on where you come in that ranking list, you'll either be suitable and selected, which means you're selected into a rotation, or suitable and not selected, which means you're on the part of the ranking list that's just outside the number of spots they have inside a rotation. And in that case, you go onto a wait list. Now, I should say, as most of you are aware, in general, medical registrars are in shortage across the state. So the people who are suitable and not selected, whilst they might not get an offer in their preferred rotation at the start, invariably they end up with a job by the end of the selection process. So don't get too disheartened if you get that suitable not selected result. It's very likely that as things change over the next few weeks, there will be a position available for you. And And then once the offer is accepted, you'll be asked to nominate your hospital and term preferences. So that's collected from the north side rotation or the south side rotation, a little bit more straightforward in Cairns and Townsville. And then allocations will be based on a variety of things, ranking, training requirements, and also workforce need. And so we look at, that's where the network sort of economy comes in. We look at what terms do people need, how can we best address that? And then when there's competition for certain spots, we allocate based on merit-based ranking. And once allocations are complete, you'll then be forwarded an employment contract covering your employment for the 2021 training year. We can, at that stage, that's when you sort of move from a HR perspective into the local hospital. So a few quick tips. It's important when you're doing your answers, just review the network selection criteria. What I put before is the short version. There's more detail on the website. In general, just read the how to apply document on our website. And if you're trying to find it, just Google how to apply for basic physician training in Queensland. That will take you to our website, and then look up the 2-year model, the 2-year network information. And as I said, if you've got that printed out or open next to you when you're going through the RMO campaign, you should be right. We'll answer some questions in a second. I just wanted to mention a couple things. So flexible training, so that's part-time training or training which is a little bit different to the usual routine for one reason or another. In general, I suggest if you've got a flexible training request, contact the network rotation coordinator of your intended rotation for advice, and they might be able to advise you who to talk to. We don't have specific flexible training positions or specific part-time training positions. We've toyed with that idea, but then we thought that sort of defeats the purpose of having flexible training. It'd be quite rigid. But as you can see, a number of settings there have flexible training positions. I've got to be honest, on the Sunshine Coast, in 10 years' time, I've got an under-10s netball team worth of progeny that could be ready to take the court. So there are flexible training opportunities, and where that happens in your training, again, discuss with your local DP with regards to your own training needs, and discuss with the various settings you might be working at. But we're willing to have that dialogue. In the end, flexible training has to ensure that it works for both the employer and the employee, but we're really trying to make sure that that's something that we can afford, because it's very important to achieving equity in physician training. I might just, before I go into the questions, one other thing which we haven't put in is also for Aboriginal and Torres Strait Islander trainees. There is a significant amount of support from the college for Aboriginal and Torres Strait Islander trainees, and suitable Aboriginal and Torres Strait Islander trainees will also get priority with their allocations. Again, that's in keeping with both college, Queensland Health, and general health priorities of our state. I appreciate it's very confusing this year for a number of reasons. We're moving from having partial network training to complete network training. There's a few changes happening. And then obviously we've got all the uncertainty with COVID and the exam being delayed. It is an exceptionally extraordinary year. Once we sort of get into the situation where everyone's on the network for 3 years, then basically everything will be planned out from year one, and it'll actually be a lot more sensible. But we're in a bit of a hybrid year, and it can be quite confusing. The first point of call is always your DPE, because whilst we know at the network a lot about the mechanics of how things work, the DPE also knows where you are in your training, and also they can approach us. We've got a Teams group amongst all the DPEs, so there's certain questions that do come up quite frequently. So talk to your DPE first and foremost, and then you can talk to us. Some of the specific questions, exactly like geographic location of accommodation to hospitals in different rotations, that might be more NRC, Network Rotation Coordinator question, and the visa question is probably best coming through us at Basic Physician Training, because it's confusing enough. The DPEs might have some insight, but it is just generally very confusing. The visa rules are something you don't want to have to deal with unless you absolutely have to, but please let us know so we can work out how to advise you. Well, if there's any further questions, please email physician_training@health.qld.gov.au, and or talk to your DPE, talk to the Network Rotation Coordinator. Their contact details are on the website. And I appreciate everyone staying around wherever you may be and listening in tonight. It can be quite confusing. We try and make things as clear as possible, but we're happy to try and clarify where we can. Everyone obviously stay safe with everything that's happening out there, and hopefully we see the world going back to normal more and more. Hopefully next year I'm able to do this presentation in person. Okay, so thanks everyone. We'll call it a night.